Good morning, and welcome to this special pre-conference kickoff session, XLH 101. My name is Susan Fados, and I'm the Executive Director of the XLH Network. I'm particularly excited about this session because there is so much information coming at you this week. I think it's good to take a moment and just get a refresher on the basics of XLH. And for those of you that are either new to the network or living in a family that's newly diagnosed with XLH, we want to extend a special welcome to you as well. The information today will be brought to you by two well-renowned experts in the field, Elizabeth O'Leary and Marianne Hart. Elizabeth is a senior clinical researcher at the Yale University School of Medicine's Center for XLH. She is also a member of our board of directors and one of the founders of XLH Day. Marianne Hart, research manager in the Division of Endocrinology, has been with Indiana University's Metabolic Bone Group for 18 years. She is recognized as an expert nurse in the field of XLH and other bone disorders, and currently sees over 100 patients in the clinical setting. Elizabeth and Marianne, thank you for your time today. I will turn it over to you.
Good morning, and thank you for being with us today. We do apologize, the captioner is running a little bit late, and so in the interest of time, we're going to get started, and as soon as the captions are available, you'll see them on your screen. So as Susan said, I'm Elizabeth O'Leary, this is Marianne Hart, and we are going to talk about XLH 101 from A to Z and birth to adulthood. The only other thing I think we need to mention before we get started is that even though we'll be talking about everything to do with XLH and even some of the treatment options, neither of our presentations should be interpreted either as our endorsement or the network's endorsement of any particular treatment, especially Crysvita.
The other thing to mention is that while we'll try and get as much information covered today as we can, we are on a limited time. So Elizabeth will share our email addresses in the chat below. So if there's something that we don't get to throughout the talk, please feel free to give us an email at the end. We do want to make sure that we try and stay on time as best we can and get you onto the next exciting sessions throughout the day. So we're going to cover a couple things today and try and get through what exactly is XLH, the genetics and the hereditary patterns of XLH, how do all the different pieces of the data and everything that you hear from the doctors, how does it all come together? How do the doctors or the physicians, practitioners look at making a diagnosis of XLH? We'll go over symptoms that are associated with XLH, including adult children and the symptoms that bridge both adulthood and childhood, as well as some treatments available, and talking for briefly about the transition and life stages of XLH.
So we're going to get started right away with what is XLH. So we're going to break it down. You'll notice much of our talk, there's acronyms, 3 little letters that really mean something a little bit bigger. So we're going to start with X-linked. All humans have 2 chromosomes that determine whether they're male or female. Females have 2 X chromosomes and males have an X and a Y. The gene for XLH, which we will talk about shortly, resides on an X chromosome. So the gene is linked to the X chromosome. That's where we get the X-linked part. Hypophosphatemia. Now, hypo means low or less than. Phosphate means phosphate or phosphorus. And then emia means in the blood. So if we put this all together, what is XLH? It is a rare metabolic bone disorder that causes the loss of phosphorus in the bloodstream. This chronic low phosphorus leads to poor mineralization in bone and teeth and can negatively affect muscle.
So many of you have probably heard of XLH called a variety of different names through the years. Below are many of the names that we often still hear XLH referred to. But highlighted in the purple is really the issues that may have caused some of the confusion with treating XLH, especially in adults. The main one being rickets, and we'll talk about this more in detail in a little bit. But rickets is a childhood disease, and as many of you know, XLH is not just a childhood disease. The other common theme here is vitamin D resistant, and XLH really has little to do with vitamin D and resistance to vitamin D. The most common cause of bowed legs in children in the United States is still a vitamin D, a lack of vitamin D in the diet. So there is vitamin D rickets still very prevalent in the United States as well as across the world, but XLH really is not associated with vitamin D resistance. So like I said, rickets is not just a symptom of XLH, or rickets is not XLH, it's just a symptom of XLH. We'll talk more about the looking at these x-rays. So remember this slide as we get later on, but the main thing we want you to take home is that rickets is just one component of XLH and not defining of XLH.
So we mentioned that XLH are metabolic. But what is rare? What is that? And we try to make our rare look a little bit like a zebra, because we all know that the symbol for rare disorders in the US is the zebra. So XLH occurs in anywhere from 1 in 20,000 to 1 in 25,000 people. So if we translate this to the US population, we expect that about 15 to 16,000 individuals will be diagnosed with XLH. And while some of the symptoms are common and shared universally among all those who are diagnosed, there is tremendous variation, and even people within the same family may have a different experience and show different signs and symptoms of the disorder. So now we'll move into the genetics of XLH.
So XLH is a genetic disease, meaning it's hereditary, and it typically runs in families. This is inherited directly from a parent in most cases. Although sometimes there is a spontaneous case of XLH. In that situation, that becomes the first person in that family to be the one to start the hereditary process or passing it down of XLH. Spontaneous cases occur in about 20 to 30% of those diagnosed. And again, once someone's diagnosed with XLH, then that begins the family pattern of passing it down.
So we'll talk about inheritance and then move on to the paternal inheritance. So if a mom is affected with XLH, we've already talked about how the gene for XLH resides on an X chromosome, indicated here as the red X. The mom has 2 X chromosomes, and so that's all she can contribute to her offspring. So we'll follow the pattern of inheritance with the X chromosome in red, and we see that a mom can pass on either one or the other. So she has a 50% chance of sharing either the X chromosome with the gene for XLH or the typical X chromosome. So she can contribute this X chromosome to either females, because then the dad is also contributing an X chromosome, or she can contribute the X chromosome with XLH to males. So again, you see in the right-hand column where she's contributing the red X and the dad's contributing a Y chromosome. So for the mother, XLH, 50% of every time she has a pregnancy, there's a 50% chance of passing along XLH, because there's a 1 in 2 chance, either the X chromosome with XLH or the X chromosome that does not have XLH will be passed along. Now for males, if a father has XLH, he only has 1 X chromosome. So that's where the gene resides. And so for fathers, you'll see the blue chromosome can only be contributed to females, because the female is getting the X from her father, and she's also getting an X from the mother. But the X chromosome for fathers with XLH is only donated toward daughters. He's giving the Y chromosome to his sons. And again, if he's the person carrying XLH, he's not passing on an X chromosome to sons. And so for a father who's affected with XLH, all of his daughters, but none of his sons will inherit it from him.
how
Now
all
Mary will
these
talk about
pieces,
how all the pieces come together.
sorry, yeah, we're going to look at how all these different pieces come together and a lot of the things that you hear your physicians or providers talk about. First is, let's talk about FEX. FEX is caused, or XLH is caused by a gene mutation in the gene called FEX. Some doctors may refer to this as PEX. What FEX does is it controls the production of the hormone FGF23. Currently, there are only over 350 different mutations recognized that lead to XLH. The mutation, though, does not identify the severity of the disease. So even in a family that we would expect to have one mutation throughout the whole family, there'll be a wide variety of how the patients are affected by XLH. Some may be more severe, where others may be very mild. So in the generally consensus is that the mutation that you have does not dictate the severity. It's also to be possibly to be diagnosed with XLH, but not have a mutation that's been recognized or documented yet. Sometimes you'll see reports that say that this is a VUS or a variation of uncertain significance. And that just means that this is the first time or one of the first times that that variation or mutation has been identified. That may change as more people have diagnosis or get their gene testing done. As more people are determined to have that same mutation, then they may change that from a VUS to a diagnosed mutation or a pathologic mutation.
So before we go on, I want to mention that we do have a question in the comments that is, my mom wasn't affected very much, but I was hit hard. If I had girls, is there any way to know how severely they might be affected?
Very little ability to know how people are affected. It seems to vary greatly amongst family members at times. So unfortunately, no, there's not a good way to give an idea of how your daughter will be affected.
Thanks for sending the question. We're happy to take all questions and we'll get to them as soon as we see them pop up on the screen. It's a little tricky with two different screens.
So next is FGF23, which I mentioned is directed by FEX. The FEX gene in everybody controls the production of FGF23. In patients who have that FEX mutation, though, the FGF23 is produced in excess. What FGF23 does in the body of both those affected by XLH and those not affected is FGF23 controls or acts to control phosphorus regulation in the kidneys. So it tells the kidneys when to turn on and turn off the phosphorus production or reabsorption within the kidneys. So those not affected by XLH, the kidneys keep the phosphorus at a normal level. Those who have XLH, though, the kidneys get too much direction from the FGF23 to get rid of all that phosphorus. So that phosphorus is gotten rid of in the urine. So this leads to what we call phosphorus wasting in the kidneys. And that's a characteristic that you may hear physicians describe XLH as a phosphorus wasting. The other thing that we don't talk about as much, but it's also a very important part that FGF23 does, is it blocks the conversion of inactive vitamin D, or vitamin D3, to active vitamin D in the small intestines. So inactive vitamin D is what you take in through your diet. It's then in the body converted, it's absorbed in the small intestines and converted to an active vitamin D3 in the liver. So, what FGF23, the excessive amount, blocks that absorption and the conversion in the small intestines. And finally, and you see our nerd humor there in the pH, finally, phosphorus. Obviously, phosphorus is a very important element in the body. It plays a role in many of the biological functions, including bone health, dental health, growth, energy storage, cell membrane formation, as well as RNA and DNA synthesis. It's important to note that almost everybody gets enough phosphorus in their diet, that taking an additional phosphorus in your diet is not going to be enough to treat XLH. So don't try, don't think that, oh, if I just drink an extra Coke or take a little extra phosphorus, that will make a difference. So in your diet. So this all comes together in that the loss of phosphorus in the kidneys is called phosphorus wasting. That phosphorus wasting leads to a loss of phosphorus in the blood, or low phosphorus in the blood. That continual or chronic low blood phosphorus levels leads to many of the symptoms that we often consider kind of the main characteristics of XLH, being the rickets at the growth plates, the lower limb abnormalities, osteomalacia, dental abscesses, delayed growth, and short stature. And we're going to spend some time shortly going over these symptoms in more detail.
We're going to talk about how someone might be diagnosed with XLH and what factors go into that diagnosis. What do we consider? So we think generally about the family history. As we know, if a mom or a dad is diagnosed with XLH, we have some sense of who may inherit it if they have children. We also consider lab work, which is the blood and the urine collections that I'm sure so many of you are familiar with. We also look to x-rays for skeletal changes in bone mineralization. And then the clinical signs and symptoms, the global appearance, the difficulties in daily living. It's really important to listen to our patients. They are our best teachers to help us understand what they're going through and how the experience of XLH is affecting their daily life. So as I mentioned, we look to the family history. Knowing that someone has XLH will help us often predict who may have it in the future, in future generations. So again, we mentioned that for a dad with XLH, he will only pass it on to his daughters. And so in the first generation, we see the dad with XLH and all of his daughters have inherited it. And then moving on to the next generation, this daughter on the left has passed it along to two of her children, both a daughter and a son. And I just want to make sure that I mentioned it before, that it doesn't matter if someone, like a mom with XLH, has had a child who inherited it from her. Every time she has a pregnancy, there's still that 50% chance. So it doesn't matter if she's had one child with XLH already, or no children, or 5 children with XLH. The next time she has a pregnancy, there's still that 50% chance, because there's 2 X chromosomes and it's a one or the other, whether or not the child will inherit that X chromosome with the gene for XLH.
Sorry. The other thing to mention when we're looking at family tree is sometimes we use this backwards and we work our way back, especially if we're seeing a child for the first time in clinic. We may work backwards and see, are there family members that may have had very mild symptoms that actually potentially did have XLH and it wasn't recognized? Or the other thing we're going to look at, is there an inappropriate passing down of these symptoms? Is there a father that passed these symptoms down to a son? In that case, we would recognize that this is not XLH and a different disease that we're looking at. So sometimes we use the family tree not just to look down, to future generations, but look back to former generations.
The genetics, I'm not sure if I mentioned it before, but that it's X-linked dominant. And so there are no carriers per se. You either have XLH or you do not. And as we mentioned before, you may have very mild symptoms, but you still will carry the gene if you in fact have XLH. So moving on to lab work, we mentioned this is the blood and the urine evaluations that I'm sure everyone with XLH is all too familiar with. Typically, patients with XLH obviously have the telltale serum blood phosphorus that is low from that phosphate wasting, and the lack of phosphorus being able to be reabsorbed into the bloodstream. And because we don't have that, again, it's not able to complex with calcium and magnesium to form mineralization properly with bones. We also have some other values that we're able to get. We look at the 125, which we said we know that in XLH, the FGF23 inhibits the conversion of inactive vitamin D to active vitamin D, and also that reabsorption of vitamin D in the small intestine. I know many people are probably interested in why they have to do so many urine collections, especially 2-hour urine collections, which are typically timed with a midpoint blood draw. And so we actually use the values that we get from the urine and the blood together to make a calculation. We do a couple of different calculations First one is a tubular reabsorption of phosphorus to actually understand how much is being reabsorbed versus how much is being excreted. And then we also determine something called a TMP GFR. So we determine the tubular maximum resorption of phosphorus, how well the kidneys are actually resorbing versus, like I said, excreting. And then some of the other values that are on the table
Sorry.
really have to do with treatment effects or to make sure that anything that we're doing to help treat the patient isn't causing side effects. Um, we'll talk about that a little bit later on too. And then the other important thing to really know and to understand is that serum phosphorus levels are particular to age. And so in children, the normal range for phosphorus levels is much higher than it is in adulthood. And that makes sense because we know as children we're growing and forming bones, and mineralizing our bones. And so the ranges are also very narrow. So you can see this is like 0 to 5 days, 1 to 3 years, 4 to 11 years. So the ranges are much more narrow, and you really need to be looking for the normals within that age range and not be looking at what it might be for an adult. And this is very important because we know many times the diagnoses have been maybe missed or overlooked or not considered because someone might be looking at the normal ranges for adults, but instead we're talking about a child. So this is very important. And again, we mentioned the blood and the urine collection. Best if done in a fasting state, but not always necessary. Really look to your provider for what they would like you to do at the time of the collection. And we mentioned a few other values that are in here. Sometimes we do look at the FGF23 level, which, as we mentioned, is elevated in patients with XLH. The alkaline phosphatase, which you may have heard, also tends to be either normal or high in patients with XLH, and it's really measuring skeletal response to treatment or the mineralization of the bones. And then something else that we do monitor is intact parathyroid hormone for potential hyperparathyroidism, which can be something that's either inherent in the disease or due to treatment. So finally, we get to x-rays and actually looking at our bones. And so I'm sure many of you have seen x-rays, but if you haven't, this is an image. It's coming from the femur and then the long bone in the leg, and we're actually looking at an area called the growth plate. And so the growth plate is the area from which the bones elongate. This is where growth occurs. You have them in a couple places in your body. There's another one in the wrist, but we're going to look at the leg right now and the knee specifically. And so we see on the one on the left is the typical developing bone. So this is very nicely mineralized. You can see the very crisp outline of the edges of the growth plate, the denseness, you can see the mineralization, compared to the rachitic bone or the bone with rickets on the right. Now you'll see it's a little bit wider. It has some like flared edges. It's a little bit more lucent, so we can see that it's not as white as the bone on the left. There's some actual lucencies where we see that the mineralization has not occurred. And so that and the irregular margin, this is rickets. And so rickets is very specific to the time period during which growth can occur and the location of the growth plate, which is why we think that maybe it was considered to be a disease of childhood, because once those growth plates close and the possibility of growth is no longer, then we don't consider it to be rickets. There's another term that we use for this poor mineralization elsewhere in the bone, not at the level of the growth plate, and also after the time period when growth ceases. And so that is osteomalacia. It's that poor mineralization, not at the level of the growth plate. So children can have both rickets and osteomalacia, whereas when we're talking about this in adulthood, we only really refer to it as osteomalacia. You don't have rickets as an adult. So in addition to all the previous information that your provider should talk to you about, we also like to talk about what you're experiencing in your daily life and how that affects the tasks that you need to do from day to day. As I said before, the most important teacher for people who are providing care for their patients are those patients themselves. You know yourself best, you know your children best, and so you are the best teacher and the best source of information for us. So we're going to move right into those actual clinical signs and symptoms.
We can start off with
So-
signs and symptoms that start in the children. I'd give you a break, Elizabeth. Let me talk for a minute. Signs and symptoms that start in children and adolescents. Elizabeth spent a lot of time talking about rickets. We've hit it obviously multiple times, as it is one of probably the most concerning symptom for parents as they start to see the lower limb abnormalities associated with the rickets. This also can lead to delayed growth in children. And sometimes it's those symptoms that first bring a family into the pediatric clinic for evaluation. And Elizabeth mentioned earlier about following your gut and really trusting that you know your kids. And sometimes it takes a little persistence to get to the right provider to take a look at these symptoms and know that it needs to be evaluated. So in children, we're looking at rickets, lower limb abnormalities. Sometimes this is the bowed legs, the windswept or the knock-kneed, the delayed growth, and I'm going to skip down to the delayed walking. All those, the rickets, the lower limb abnormalities, delayed growth can all lead to that delayed walking, and sometimes that's the first symptom. Craniosynostosis and Curare malformation also occur in children. They can occur outside of the XLH population as well, but they do occur at a little higher incidence with the XLH, and that goes along with the frontal bossing and just the abnormal shape sometimes it occurs of the head. So these are in children and adolescents. As we go into adult and children, some symptoms are shared by both groups. This would be the osteomalacia that Elizabeth spoke about, to just a general lack of the phosphorus within the bone. Obviously, the short stature is going to continue into adulthood. Bone pain, joint pain, often this is difficult to discern the two. Enthesopathy, and we'll talk a little bit more about what exactly enthesopathy is, as well as dental abscesses and muscle pain and weakness in adult and children can be present.
Dr. Rodbeer Carr talking specifically about the dental complications of the disorder.
Yes, he'll be doing a nice panel presentation, I believe, later this morning discussing that. In adults, we were looking at hearing loss because the bones in the ear are what control hearing, so we expect those bones to be affected as well. Osteoarthritis, as for many people, we've changed the mechanics of the body because of the bowing of the legs or the knock-knees of the legs. So oftentimes people start to experience osteoarthritis at a much younger age than in the non-affected. Sometimes this is in their 20s and 30s. This can often lead to early joint replacement requirements. We also see pseudofractures, and pseudofractures are where the bone starts to fracture kind of on the outside leading in, but it doesn't go all the way through the bone. So it's not what you would think of, of someone falling and breaking a bone in half. Pseudofractures are just also can be called stress fractures, but they don't go all the way through the bone. Unfortunately, though, those pseudofractures can stick around for a long time. They can be very painful. And for adults, this may be the symptom that brings people back into clinic after they've been away for a while. And what we're trying to prevent is those pseudofractures from going into full non-traumatic fractures. So those pseudofractures progressing into a more significant fracture. Spinal stenosis is associated with enthesopathy. If we didn't have, so enthesopathy is the calcification of the tendons that and the tendon insertion sites of the bone. So the tendons are basically what keep our body from just being a bag of bones. Without tendons, our bones would just kind of fall into a big blob of stuff. So the tendons are what keep the bones in place along with the muscles. Those tendons can become calcified. When that occurs around the spinal column, that leads to spinal stenosis, or is what is considered spinal stenosis. That then can put compression on the nerves that are exiting the spine and can lead to symptoms like numbness and tingling in their feet or their hands, weakness, pain, So those are sometimes symptoms that often are associated or not associated with XLH. So a patient, as an adult, starts experiencing those, not considering that related to their XLH, and oftentimes seek lots of different treatment or care. And this is really is stemming probably from the XLH. Due to the clinical trials, we found out that restless legs is not just a side effect of treatment, but actually is a symptom of XLH in itself. We wish we had a better understanding of what causes restless legs, but it's definitely present in XLH patients at a higher incidence than we anticipated. So restless leg is definitely an associated symptom of XLH.
All right. We want to talk a little bit about enthesopathy, and we wanted to offer you a little bit easier way of trying to pronounce it, because I know it trips up a lot of people. It trips us up too, especially when we're saying it over and over again. And it may vary based on where you are in the country, but enthesopathy is one of the characteristics that we find that many patients with XLH start to experience in late adolescence, definitely in adulthood. Start to see it usually in the 20s. And so enthesopathy, as Marion mentioned, it is the calcification of the insertion of the ligaments and the tendons. As you can see here, this is the Achilles coming into the calcaneal, and we see that there is actually a inappropriate mineralization right there. There's a couple other ones over down here on the screen. I don't think I have the pointer available to me, but sorry, I have a message that I've been signed out. Give me 1 second. Marion, maybe you can take over while I figure out this technical difficulty.
Yeah. So what Elizabeth is saying is you see 3 arrows there. One is on the top, that would be on the top of the foot, and you see that little hook. Same thing on the bottom of the heel. This is looking sideways through the heel. So the top is going into the tibia. Going to the left is to the front of the foot. So that bottom, you see that hook there? This would, basically in enthesopathy, see, it trips us all up, is a bone spur, or what a lot of people would refer to as bone spur. So in this case, it looks like a heel spur. They're just much more prevalent in XLH patients. So you see it coming up the back of the heel, below the heel, and then on the top of the foot. Normally we would expect this bone to be really fairly smooth and a nice rounded back side of the heel. So there you can see the enthesopathy is present in the heel. This can be very painful for patients as well, and a lot of times requires special considerations as far as lack of movement. Sometimes it's in the elbows, and patients can't straighten their arms out fully, and their shoulders, and that they can't raise their shoulders or their arms above their head. So it's definitely a very impactful symptom of XLH. Something that we're still also trying to figure out how to quantify or determine the severity of it, how to test for it. As far as from a clinical standpoint, we don't normally do x-rays to determine if you have it. If you have restricted movement, then we're going to assume that that is probably related to enthesopathy.
Yes, so that's a very good. So I'm back, and we wanted to just pound out our point that XLH really is a whole life condition. Many times patients will ask me, well, is this a kidney disorder? Is this a bone disorder? Like, what is this? And so I typically like to say that it's whole body, whole life, because there's very few locations in your body that there's not, like as we mentioned before with the ear, a very small bone. So whenever there's mineralization, whether it's your skull, your limbs, your ear, wherever there's mineralization, your teeth, there's the potential to have some sort of complication from XLH. And as we mentioned, not everyone has the same signs and symptoms, but it's possible, and we want you just to be aware. And then, so it's whole body, but it's also whole life. We said XLH is not just a disorder of childhood. You may have certain symptoms during childhood that resolve, some that will remain, and some that will appear later in life throughout adulthood. That underlying hypophosphatemia does not go away. That will remain throughout life and continues into adulthood with, again, those new signs and symptoms that may appear. So we do recommend that periodic clinical evaluation continues throughout the lifespan to not only assess disease progression, but to evaluate and reassess treatment options, treatment response, if you are being treated, and the therapeutic complications of those treatments. And so we do hope and recommend that you maintain a relationship with an XLH specialist, and whether or not that's an endocrinologist or a nephrologist or a geneticist or the rest of the team that may be part of your care, whether that's orthopedics, the dental professionals, a physical therapist, a rheumatologist. There really is a whole host of providers who you may encounter and you may want to get to know throughout your whole life with XLH. And once again, we just wanted to show the signs and symptoms and how some are specific to the pediatric and the adult time period in life, but some are very common and go with you through the lifespan.
We're going to jump next into treatment. We're going to go through this fairly quickly, as treatment is really something that you need to discuss with your provider. We'll just give you a quick overview of some of the options that are available. The important thing to note is the treatment goals. What are we looking for when we look at treating XLH? Obviously, for children, it's the correction of those lower lip abnormalities, whether we achieve a partial correction or a full correction with medication. Regardless of treatment, sometimes these abnormalities will require surgery for some patients. So we're hoping, though, to be able to decrease those number of surgeries that are required and optimize their adult height. For adults, we're looking to reduce pain symptoms, reduce the effect or the extent of the osteomalacia, and improve fracture healing or surgical recovery if it does progress to surgery. Looking at conventional treatment, which is what is oral treatment, this is actually has been around for the last 40 years. It is considered, it's the oral therapy that many of you are probably familiar with. Some of you on the call have probably were on treatment prior to the 1980s and have many stories of the different treatments that you've been on. But since the 1980s, the conventional treatment has been phosphate replacement in the form of oral phosphate salts. These can come in a variety of different versions, Fosnac, K-Phos, as well as an active vitamin D 125. And in the US, this is often calcitriol or rocaltrol. Phosphate doses require titration as well as the calcitriol. Some of the side effects associated with these, just kind of immediate side effects, are abdominal pain and diarrhea. With these medications, we do not expect to see normalization of a serum phosphorus level or their blood phosphorus. We're really looking at trying to improve the children's symptoms, looking at x-rays, some improvement of their phosphorus. We will achieve some improvement of their phosphorus, but we're not looking to completely normalize it. If we normalized it, it may require fairly high doses, and those can lead to negative side effects of nephrocalcinosis, which is calcifications within the kidneys, high urine output of calcium, and secondary hyperparathyroidism. So, we do our best with the oral medications, but we do have to really balance those and monitor those closely. It is important to note that phosphates should not be taken alone. So you should not just take an oral phosphate without an activated vitamin D. So this is something that sometimes we'll see a patient who gets a lab drawn at our primary care provider, and they're like, oh, their phosphate's low, you really should be on a phosphate supplement, and that should not be taken by itself. So that's an important note to state.
And so recently, very recently, there's been an FDA approved for the first time treatment for XLH known as burosumab, or you may have also heard of it called Crysvita, which is actually designed to target the underlying cause of XLH. With the phosphate and the vitamin D, we're really trying to sort of replenish the loss. And as you can understand, that's really a tricky, complicated process with also trying to mitigate those side effects. But Crysvita, or the burosumab, is actually targeting the biological activity of FGF23. it's an FGF23 blocking antibody. And so by blocking the FGF23, the renal phosphate wasting is minimized and the reabsorption is then restored. So then we're able to um, bring the serum concentration of phosphate closer to normal levels. We're able to normalize it. And then also that conversion of inactive to active vitamin D is also remedied. So in the US, burosumab was approved, and also in other places around the world, it's starting to be approved, although it's a little bit different in depending on what country you're in and what area of the world. It's very specific. So I encourage everyone who's not in the U.S. and on the call to speak to your provider and find out what's going on. There's some new developments recently, as recent as yesterday. It was announced for the older population in Europe, but in the US, it's indicated for children and adults 6 months of age and older with a diagnosis of XLH, but not for use with the previous treatment that Marion mentioned, the phosphorus and the active vitamin D. So burosumab is by itself. It's used by itself. However, we do know, and we've heard that there are some questions about people who are on burosumab, but also being asked by their provider to take vitamin D. Now, this is not the active vitamin D, the calcitriol or the rocaltrol. People are being asked to just take the inactive form of vitamin D. And that's because those of us who live in the Northern Hemisphere, we all are at risk for being low for vitamin D in general. Not dangerously low, but not where we want our levels to be. And so if you are being asked to take over-the-counter vitamin D with burosumab, and your provider is suggesting that you do that, that is okay. I take over-the-counter vitamin D, and many of us who do spend a lot of time inside or putting sunscreen on our bodies will probably need to do that as well.
So we're gonna.
I think we have just a couple minutes.
Yeah.
Stages. I'm going to let Marion take over.
So yeah, we want to make sure that you guys are able to take a break before the next session starts. So we're going to just kind of go through this very quickly. The important thing to consider, and what we've tried to impart through this whole talk, is that this is a lifelong disease. So you have to plan transition of care. While some doctors, like Dr. Emil here at Indiana University, are adult and peds and can follow someone for their entire lifespan, that's not the case in a lot of situations. So we need to plan ahead for transition of care. This is not something that can be done very quickly or very like at a sudden kind of thing. It needs to be planned. So we want to make sure that you're thinking ahead if you have children, that you're determining who's going to be taking over the care of the child once they reach 18. But the other thing is the obstacles to transition of care. And one of the big things I want to mention, and then we'll wrap this up, is a lot of patients have what we call a honeymoon stage. So as they reach adulthood, they're feeling pretty darn good. They don't really feel like the XLH is bothering them that much. So a lot of times they'll slip out of care. You know, we'll lose them to continuing care. And it's important that we do education to recognize that this is a lifelong disease. If you continue to be monitored throughout your lifespan, then sometimes we can head off some of the symptoms that appear later in life, or make it easier to get back into care if we just recognize those symptoms. So just realize that it's important to continue care throughout the lifespan, and not just you know, as the child leaves adolescence, they're done growing, they're feeling pretty good, that we don't want to lose them at that point. We want to make sure that we're able to continue to provide care for them, head off symptoms that may start early and are often recognized related to XLH.
I think before we close, time for a few questions. I mentioned that obviously we've made ourselves available to you. We've provided our email in the chat, but the XLH Network obviously is offering this wonderful XLH week when there's so many wonderful speakers and so much educational information, and also the opportunity to really connect with others who are in the XLH community. So we offer, we suggest that you take a look at all of those wonderful presentations that are coming up after us. We hope that we have really laid the foundation, but we do have time for some questions. There's also several other resources that are available to you, both organizations and online resources. We do have time for some questions, so we're happy to take them.
Thank everyone for joining us so early, especially on the West Coast. We know that, Saturday morning we've gotten everybody up, hopefully got a good start going for the day.
Yeah. We'll take a few questions if you have them, and then we'll give you the opportunity to stand up, take a little break before we continue on with the day. I'm going to check the chat.
Elizabeth and I could probably talk about XLH for hours and enjoy, I think, talking about it and educating patients on it. So anything in the chat?
Yep, we do have a question about if there's any research being done for hearing loss, which I'm not familiar with at this time.
No, I don't think, not that I know of. I know that we are collecting it as part of the long-term 10-year study. They're collecting data regarding it, but as far as, changes in treatment or anything like that, I don't know of anything ongoing.
Then are we finding patients taking Crysvita to have less, more, or the same level of enthesopathy?
Wow, we'd love to be able to give you a great answer on that. Enthesopathy is something that develops slowly over time, and therefore it's not going to probably go away, if at all, with Crysvita. It'll take us a long time to know whether Crysvita will change the development of enthesopathy. So that's part of the reason that there's 10-year studies going on looking at the long-term effects of Crysvita. So tune back in 10 years and maybe we'll have a better idea. I wish I had great news and could tell you that yes, it would, but we cannot make those promises at this point.
So there's quite a few questions that I think I can't see, but that are coming in. And I'm just a little concerned that we won't be able to give you the break that you need and that the tech support needs to transition to the next speaker. So I am going to take these questions with us. And in fact, I may even pass them along to Dr. Carpenter, Dr. Immel, and Dr. Insonia, who are coming on in about a couple hours. And hopefully that they'll be able to take over from where we left off, just because we want to make sure that everyone gets their questions answered. Obviously, keep them coming. We will take them back with us. Anything that the doctors, the three of them can't answer, we'll be sure to get you the correct information. All right, thank you so much. Like I said, we're going to take a quick break, and then we'll be back at noon with our keynote speaker, Nicole Boyce.
Thank you.
We're